Hello, can you hear me?
Yes, Prof, we can hear you.
Okay. Good morning, everybody. Good morning, everybody. I am Dr. Tohu. It is indeed an honor for me to act as a chair in this scientific section regarding laparoscopic surgery in COVID era on this 67th Myanmar Medical Association annual conference. So, well, this small infecting agent has caused a lot of trouble to this genius uh, of creature, mankind, for the past year, and we are now living in a new normal, and we are trying to cope with COVID very difficultly, especially in our country. Well, today, this COVID has caused a lot of trouble, not only in every field of this mankind, and laparoscopic surgery is also a big problem because this COVID is transmitted by this aerosol transmission and this small one. And we are dealing with, in laparoscopic surgery, this is also a trouble. So today, there are three experts who will be talking on laparoscopic surgery in COVID era. So, one from Philippines and two from Singapore. In fact, one from Singapore is also our fellow countryman. So without wasting time, I would like to introduce the first speaker. First speaker is Dr. Alfred Allen Bonifay. So he has been with us for the past almost 10 years now. He has been to our country more than 10, 15 times. And Alan is now Executive Director of Philippine Center for Advanced Surgery. He was the past President of ELSA and Joint Secretary of APHS. And he is also Board of Director of Joint Secretary General of Asia Endosurgery Task Force, Asia Pacific Endo-Laparoscopic Group. And he is also editor of Asian Journal of Endoscopic Surgery, which is an official publication of ELSA. So may I invite Dr. Alfred Allen Bonifay to talk on laparoscopic hernia surgery in COVID era. Alan, please.
Good morning, Prof. Thank you. Can I start sharing my PowerPoint? Can you see my lecture now?
Can you see?
Let me start the...
You can see it.
Okay, can you see now?
Yes.
Anyway, good morning. Thank you. Before I start, I would like to take this opportunity to thank the organizers of the 67th Myanmar Conference, Medical Conference. We miss going to Myanmar, especially Yangon and Mandalay. We miss everybody coming over. So anyway, my lecture will be about laparoscopic hernia surgery during the time of COVID. I think last year started the greatest change in the medical field, not only surgical wise, but in the whole medical community. During that COVID-19 pandemic that started in Wuhan, China, early of 2019, November, I think, started, and then became a big problem for Wuhan in December of 2019, and then became a worldwide problem in 2020, which really literally stopped the world. It stopped a lot of us, change on how we move our lives during that time. The COVID-19 pandemic really has resulted in a lot of significant changes to the surgical practice per se, primarily because of the fear of having the COVID and then transmitting it and then getting all the complications of COVID-19. Practically during those times, during the early times of the pandemic, you look on a lot of societies, and being not able to understand what SARS-CoV-2 or the COVID-19 reaction during that time, the things that we only know is the mode of transmission can be transmitted through respiratory droplets or direct contact with the person who has the COVID itself. And of course, the fomites, whatever the person touch, obviously you'll have, just like how much a simple pneumonia can be transmitted. So the initial response of all the societies, if you look on several societies, it started with the Society of American Gastrointestinal Endoscopic Surgeons, and together with our own society, ELSA, one of the authors of that paper, actually landmark paper, is David Lomanto, is one of our speakers, really halted the procedure of MIS, because the purpose of that guideline is to prevent and then to protect the healthcare workers. So the initial response is to halt all MIS procedures because it's a aerosol generating procedure, and the possibility of an increased risk of transmission because of this aerosol transmission. Excuse me. So if you look on the evidences and all the scientific papers that came out, the first one came out was the SAGES guideline, and then the EAS recommendations for minimal invasive surgery, primarily because we're doing a lot of laparoscopic surgery. So they halted all, and then they came up with a lot of guidelines and a lot of recommendations on how to go about the surgeries, even for open surgery. We stopped on all our elective surgeries, but obviously people would come in needing emergent surgical procedures on them. And guidelines on how to prepare and how to do these procedures are given out by such societies. The lecture is about laparoscopic hernia surgery, and the only society that came out with a guideline for this one is the European Hernia Society guidance for the management of patients with hernia during the COVID-19 pandemic. The Asia Pacific Hernia Society was able to come up with our own guidelines, but we weren't able to publish the guideline. So anyway, if you look on the European Hernia Society guideline, we can look on it as a general rule. The elective surgery was postponed primarily because of not being able to understand the normal, the natural history of how a COVID-19 would really react, and plus having all those guidelines coming out. And the focus of the guideline and the focus of the treatment was, of course, for patients needing emergent surgery. But then, of course, you have also to look on all the procedures, all the patients that were lined up prior to the COVID-19 pandemic, and then needing these patients needing elective surgery later on. But then again, there's one principle that would stay even with the pandemic, that the surgical technique and the materials that we need for doing a hernia surgery, either your inguinal or your abdominal wall repair, do not change as a consequence of this pandemic. So everything else, the principle of the treatment would always stay the same. The only thing that would change would on how, the manner on how we do the procedure and how we protect the patient, and obviously on how we protect the healthcare workers, especially the surgeons and the staff. We have to remember that hernia surgery primarily is an elective procedure, and the aim of the surgery is to improve the quality of life of the patient. If you put the patient on a higher risk because of COVID-19, then we go against the principles of doing the treatment for patients. So the aim of emergency hernia surgery is, number one, is to save life or resect any dead tissues or any dead bowel, restore GI continuity, and of course the repair of our abdominal wall. Again, I would like to reiterate, the surgical procedure is always the same. The operative procedure may be that may be required can be staged procedure or a primary approach. So if you look on the guidelines of AHS, looking on the groin hernia, basically the guidelines are quite the same on the same guidelines for all hernia surgeries, for all hernia associated societies. So primary ventral and incisional hernia repair, emergency repair of umbilical or pegastric hernia should be always tailored to the patient and the hernia characteristics, obviously. And of course, the use of hernia mesh, the meshes should be considered when you're when you're dealing with either a clean or a clean contaminated surrounding. So primarily all these procedures, all the recommendations would always be the same with how we recommended prior to the onset of your pandemic. Even for anatomical reconstruction of your abdominal wall, uh, looking on as a priority in emergency repair, uh, an extra peritoneal mesh placement should be considered primarily because of you would want to have an improved clinical condition or clinical outcome for a patient, especially patients who has COVID-19 infection. And obviously, the current or possible need for further mechanical lung ventilation. So these are the things that should come into mind, and the general recommendations coming from the European Hernia Society would state so. So in cases of large defect, again, to minimize any significant increase in intra-abdominal pressure, a bridge repair should be considered in this patient. So obviously, patients coming in uh, because of an emergent procedure, an emergent need to do a procedure, but a patient with either a COVID positive patient or a COVID suspect patient, case-to-case basis should be geared towards treatment of the patient. If you look on the question of minimal invasive surgery being safe in an emergent setting, looking on the initial guideline, the laparoscopic approach can be performed in a carefully selected patients for groin hernia as well as primary incisional hernia. But later on, I'll show you some of the findings and some of the recommendations from the societies right now. Because lately we've been trying to understand, or we're trying to be able to learn on the natural history or the natural course of the infection itself. So let's look on the AHS recommendation or the European Hernia Society recommendation. So number one, until now, there's no evidence for the contraindication of laparoscopic approach. Uh, if we remember the initial recommendation coming off from the Society of American Gastrointestinal Endoscopic Surgeons, where they actually were warning us of the possibility of an aerosolized and the possibility of infecting the whole team. If you look on laparoscopic approach, because in laparoscopy, there's uh, a controlled environment of the plume, even though it's an aerosolized procedure, because of a lot of mitigating procedures like putting a smoke evacuator, a plume evacuator. You can actually be you're off safer doing the surgery when you're doing it laparoscopically rather than the open, where you have an open abdomen and all these plumes or this smoke can be transmitted outwards. So looking on, the laparoscopic approach seems to allow better control of the smoke or of the plume rather than comparing it with the laparotomy. Number two, uh, care should always be taken, excuse me, be taken because of the presumed risk of your virus exposure from the intestinal content, regardless whether you're doing it laparoscopically or endoscopically or even for the open. But more so because when you're doing an endoscopic procedure, especially for if you're doing your colonoscopy, extra care should be done on this patient. Right now, a lot of companies have been coming up with some sort of a smoke evacuator for endoscopic procedures. The desufflation of any gas from the pneumoperitoneum through a virus filter is recommended. I'll show you later on how we personally do it in our center. If you don't have the smoke evacuators or even the plume system, you can actually make a modified one wherein you can suction it, and then the other tube will be soaked in a virucidal reagent, and everything would be controlled. The plume or the smoke can be controlled. So fully desufflate the abdomen before extracting any tissue or any specimen. and care when inserting equipment such as mesh or sutures through any port. So wear personal protective equipment or your PPEs as per local recurrent guidelines, especially so if you look on the guidelines of the endoscopic and laparoscopic surgeons of Asia, where we look on the cases of the community cases of COVID-19 in your area, and that's where you you decide on what PPE level of PPE to wear for such procedures involving either COVID-19 positive or suspected patients. For number 5 recommendation from the EHS recommendation, surgeons should choose energy devices with care as well as in the open surgery, and avoiding such procedures that can produce more particles. Examples of which are the ultrasonic devices like your harmonic scalpel, your ultrasonic devices. Trocar wounds should be kept at a minimum length to avoid your air leaks around the port. And these are all the recommendations that are similar to the EAES, SAGES, and ELSA recommendations early on during the start of the pandemic. So general principles in elective setting, the question of can hernia repair be safely postponed? Obviously, we've postponed our elective procedures at the start of the pandemic. But looking on the evidence, especially for patients who have came in at the emergency room with a incarcerated hernia, can a watchful waiting be done on these patients? And looking on, is it safe to do a watchful waiting for our patients? So evidences would show us that the probability of requiring emergency repair for those patients who undergo a watchful waiting stance because of the COVID-19 pandemic, looking on it, there's a very small chance of needing an emergency procedure for these patients. But for patients with femoral hernias who have at least 40% chance of needing an emergency procedure, these are the patients that you would want to really watch out for and to really follow up on these patients, because you don't want them to come in late in their disease process. So trusses and binders for symptomatic relief and prevention, there's no evidence about it with regards to the trusses, but the guideline states that if a trial of a binder is not unreasonable and provides relief, then we could try advising our patients to do trusses and binders. So this is how we do it in our center. This is our operating room at the Carlos Santos Medical Center. And basically, on how we operate our patients right now, regardless of the all elective procedures, by the way, in our institution, should undergo RT-PCR, and patients undergoing elective procedure should have a negative RT-PCR result. Patients who needs emergency procedure would always be treated like a COVID positive or a COVID probable case patient. And these patients are being done in negative pressure rooms and an added form of PPE to protect the whole medical staff. So these are the things that we do in our center. So we do a lot of mitigating strategies, like doing your procedures in negative pressure room, evacuation of your surgical plume, and of course, the usage of your personal protective equipment. For aerosolized generating procedures, especially like your laparoscopy, aerosolization of your viral particles, we all know can be a possibility in laparoscopy. Okay, hence, when we're doing it, this is a negative pressure room. Outside of that room, we have we place a barometer just to be able to check if the room is really in a negative pressure. Even if you open the room, the pressure of that room should always be in a negative pressure. You can always look at this as -1 to -2. These are the PLUME devices. uh, plume devices that can actually suction the smoke. So once you turn this on, you can actually move you can regulate the smoke evacuator. In
Alan, you lost your voice.
This is a smoke evacuator machine where you can actually connect a hose and connect it to a suction device. This is a smoke evacuator with ULPA filter and can actually suction the smoke and the plumes generated while doing your procedure. So you deflate the abdomen, and prior to removal of your specimen, evacuation should be done on these patients. So this is how we do it. These are our own protective, personal protective equipment, or your PPE. So just to show you on how the transition from a full face mask going to a modified mask, this is actually my a generating air generating device connected at the full face mask, and of course your PAPR right now. So what we're using right now in our center is our PAPRs. So in summary, the indications for surgery and the benefit of your minimal invasive procedure should always hold true even this time of the pandemic. And the only thing that has really changed is in the manner of how we perform the procedure, and of course the addition of safety protocols, thereby decreasing the risk of hypothetical viral transmission. That's the end of my lecture, and I would like to thank everyone for their kind attention. Thank you.
Thank you very much, Alan. So the Q&A section will be only after all three speakers has finished their talk. So I'm going to introduce the next speaker, who is no other than Professor David Lumendo. He's a professor of surgery, senior consultant surgeon, director of Minimally Invasive Surgery Training Center, and director of KUTEC Fort Advanced Surgical Training Center, Department of Surgery, Yonglulin School of Medicine, and National University of Singapore. David is the past president of ELSA and is also a general secretary of ELSA, who have developed laparoscopic surgery in our country for the past 10 years. So he had been to many parts of the country conducting many basic and advanced training in our country. So now David is going to talk on changes in training of laparoscopic surgery during COVID era. Professor David Lumendo, please.
Thank you, Professor Tunho. It's always a pleasure to come to Myanmar, even though virtually. You know, we have a special relation. Also, almost this year is 10 years, if you remember, it was 2011.
Yes.
And we, thanks to you and to all our friends, Tida, Momo, Professor Buimin, of course, and many, many more, I think we have a chance to have a great collaboration. Before we start, I think it's time to share with you. I prepared some slides. To talk about the change that this situation brought to us. Training that affect at any level, not only the medical student, but the resident, even the junior, even ourselves, because our continuous CME has been affected. We know that when everything started, the infection started in last, let's say, November, December 2019, until the world realized that there was something very serious. It took almost 3-4 months, and probably all around that I'm saying in Singapore, the restrictive measures started about February, March 2020. I don't know if it was just the beginning, but the beginning was exploding worldwide with the curve of infection going up without any control, and affected all the business, not only the healthcare. Of course, healthcare as a primary impact because it's a pandemic, but in manufacturing, banking, consumer, retail. So it was really a disruption. A disruption at any level. I don't know when we will be back to our normal, like before COVID, but this was very fast, very unexpected, and probably underestimated by many countries and many people. That's some people really, like in this vignette, you can see, no thank, we are too busy. And was a little delay. Probably that's why we are experiencing now millions of people infected and a million of people also die of this. And this was something that I don't think me and Aung was terrified when we received this email. It was early March 2020. I just came back from my honorary fellowship award in Edinburgh. And I was just talking with Michael Griffin and all the committee to start to do something together. And there was some conference in Myanmar, everything was canceled. Hospital give you a warning, we can't even move from home. And there was a change. It was a change in terms of prioritize resources, keep the doctor and the team, healthcare people safe, and also the normal population. We were able only to perform emergency surgery. We was very fast moving towards a structural phase for control infection that we call DORSCOM, from yellow to orange. I think we never experienced yellow, probably only early January. We moved to orange, so means high alert very, very fast and very soon. The main objective was just to maintain ICU bed and capacity of hospital, because we don't know. And of course, there was a lot of guideline, and we will look also at our Asian situation. That was a bit different because, as you know, in Asia with the SARS, with the swine fever, we were more experienced compared to the Western world in controlling the pandemic. And you can see the number today are much lower in Asia compared to worldwide. So that's why we come up soon with some kind of guideline how we can continue to work. So we should avoid some after hours. We should limit the number of staff in OR. We should go no inside the OR during intubation, extubation, because of the high risk. And most of the times, that is probably inherent to this, our trainee were banned to join OR. Why? For many things, because surgery must be fast, must be run by consultant. We cannot expose junior people. And so a lot of safety issues arise. So the training was affected very badly. You can see how, for example, the clinic in a different specialty like upper GI went down to almost 30%. The outpatient visit, operating room, waiting time increased. And indirectly, if you understand this one, this is all exposure for our trainee. When we don't see patient, when we don't do surgery, our trainee have less training. Plus, the medical students were banned, so there was no more on-site activity. Everything was moved towards simulation. At the time we were doing the MBBS exam, even the MBBS exam we conducted virtually. It was a very big experience, a very unusual experience with a very reduced number of examiners, no more foreigner. Usually we have observers from outside, divided in small group and segregated. It was a very, very big workload. So school was closed. So education was affected. You can see 1.4 million people at any level, medical school, non-medical school was affected. So the surgical volume is significantly. So we were concerned also about the using of PPE, the supply, the cost. So training were really, the surgical training very penalized. And some of them, they volunteered, they were deployed to support emergency rooms, to support also the spread in the community, and were also affected because they need to support in many countries worldwide, to support colleagues affected by COVID. So they need to adapt and continue to be a doctor without training. So this was a big disruption. As you know, many specialty can still do online, but surgery is a skill-based training. If we don't do surgery, we cannot teach and they cannot learn. It's very important that the trainee gain experience in operating theater, in endoscopy, with a pure and so on. Nothing can be replaced by virtual. So there was a completely halt at the reaching and of proficiency, and proficiency also need to be demonstrated by a skill. So you can see that there are some paper. The impact was loss of confidence, and the loss of confidence was mainly for the junior. If you look at sub-specialty, mainly for the junior, like the trainee at the surgical level of 2, 1, 2, 3, because are the one less exposed, while the senior, they still continue to do some of the procedure. But what is important, for example, for laparoscopic surgery, you can see that most of the case, laparoscopy, appendectomy, are done by the senior resident, and everything was stopped. So the total number of surgery done by trainee as a first assistant or surgeon was completely brought down. There was a dramatic reduction in emergency, in oncological cases, and so on. But I must say that we are living a wonderful era in which digital is taking care of many activity. So no more everything goes around the people, but the technology moves, the people moves around the technology. You must look at some company that like Uber is the biggest company, but they don't know any taxi. Netflix is the large movie house, the biggest cinema in the world, but they don't know any cinema. So you will see the Airbnb, large accommodation, but they don't know any hotel. So I think there was already a shift, and the pandemic, I think, accelerate the adoption and fast changing that allow the technology partially to take over, adapt to the new reality. So the innovation was no longer an option for training, but really was essential for the survival, for continuation of the training that we provide, because the world cannot stop. And everybody, 1 year, 2 years, getting older, people retire. We need to have a new generation to take over. So there was a starting on developing of online resources, utilization of surgical simulator, video material, telemedicine, teleconsultation. So we were able to restart slowly after the acute phase to do some training in a different way. Even the social media were able to set the changes and communication in healthcare. So during this phase, some report and saw that there was a reduction, we can see, of from 84 to 44% of laparoscopic procedure, almost half. That, as I say, most of the procedure done by the resident. And then they decided to start to do webinar, they start to do artificial intelligence technology, simulation, and so on. There was a lot of data. But at the same time, if you look at the structure of the training, not many countries were able to adapt technology. So the COVID situation highlighted also the deficiency of some surgical training program, especially because of cost or because other stuff. there was really a lack of resources for online teaching, virtual teaching, and video material. So we slowly were not able to follow up. And anyway, there was a big collaboration worldwide. For example, school in Singapore, even primary school and secondary school today, they have a mandatory curriculum of 2 days per month of e-learning. So the people are much better prepared in some country compared to others. Of course, the situation was not able to be sustainable, and we need to prepare also, because we can control this pandemic, but maybe one more will come because of the too many issues. Traveling, exchanging, mutation will happen. So we need to be able to drive the changes thanks to the pandemic, adopting new module, updating maybe our curriculum, introducing a new technology in learning, making good use, maybe utilize social media, utilize video technology advances for teaching like virtual reality or mixed reality to prepare our trainee, our program better. So we need to follow the 5 steps when we move towards digital transformation. And the 5 steps are to identify, to build, to decide, establish, integrate within the surgical curriculum, for example, the digitalization. I will just go through, for example, what as ELSA, because as a society we are more dynamic, we were able to move towards different and adopt different new technology to introduce online teaching to junior doctor, even the trainee. For example, video presentation, lecture, surgical video, surgical step were put online and the big material for the trainee to adopt. A webinar was organizing, be weekly, a lot of in collaboration with many countries, and there was already a way to bring the education to the people instead to go and organize conference. And the next step, I think we will be launching soon, are the online LMS platform that is almost, that is ready. I will be able to show you something soon. And create a training program that anybody can use, even the surgical trainee that we will adopt, in which what was done on site will be translated with the blended or hybrid technology. We have online course, we have a video master class that we can provide, for example, for laparoscopic training box in each hospital. They can practice at their own pace and time, and then they can upload the video of their own skill and get a certification or with the local mentoring. So this is all course that we are developing, and I'm sure they will come up. For example, I will show you the course that we are launching. We are launching soon. Where is it? We are launching soon. We are launching. Can you see the video? No.
Not yet.
Okay, it will be soon. Yeah.
The use of electrocautery has been mentioned from the ancient days, and a lot of evolution has taken place in this field in the last century than before. If you slide over the bar on the right side, you will highlight the milestone in the surgical energy evolution. The use of electrosurgery has improved the surgical outcome by leaps and bounds. Also, the operative time and the postoperative duration has been reduced.
Also, we will have we will have also tests and courses.
This presentation on advanced energy and hemostasis in minimal invasive surgery focuses.
You can see the test here. So we will have a lot of information now that are possible to do online. And of course, we will move on also towards a mix, I say, blended reality. So what are the benefits? It's more cost effective. We can digitally scale up and grow in any way. Of course, they will require some changes in the way we do the business. So a virtual and blended learning will be We already started this recovery phase, at least in many countries, but probably we will need to adopt in a post-COVID era. We are moving towards, at least in Singapore and some of the other countries like Taiwan, New Zealand, Australia, we are moving towards a bigger group, bigger opportunity to have a small conference, small seminar, maybe at the local level, still not with people traveling overseas, but this will be with vaccination, we hope, soon in the next phase. And I believe we will need to look at the more integration. So a blended on-site learning, online learning too, distance training with supervision, adopting of virtual simulator, bench model, and so on will be the new future in surgical training, based on experience of COVID. So, but are we not ready for the change, unfortunately, because even the certification and the qualification exam that has been postponed must be readjusted to the new reality, because this will require new educational requirement and there will be new demand. Even in Singapore, we use the American board, the CGME. This has been affected for now, has been postponed, has been redo in a different way, but probably we need to look at the completely new type of qualification and proficiency. So what will be missing the surgical training? I think medicine and surgical also depend on much human interaction between doctor and patient. Also, human networking is very important, and skill are very important that cannot be substituted with the online, but can be redeveloped in a different scenario, and same as a clinical examination and also surgical skill. Thank you very much, and I hope that I've shared with you some information about change in surgical training for now and the future.
Thank you very much, David, for very informative lectures. Well, indeed, surgical training has changed a lot. So, in many years ago, well, we have to travel, we have to pay a lot of money to get a training. Then, after some time, experts like David and Alan and Kwame Yu come to our country and give training. So, more people can get that kind of training easily. But now that we can get training online, so more and more people can have improved their knowledge. But well, skill-wise, we need to improve some more. So
yes, you, David. We need to change. David. We need to change the way we transfer skill.
Yes. So we'll go on to the last speaker. Well, it's an honor for me, and I'm very proud to introduce Dr. Aw Mien Ooh, who is our fellow countryman, who had his basic degree from our country and training abroad, and then now working as in a good position in other country. Dr. Aw Mien Ooh is the Deputy Chief Medical Informative Officer, Senior Consultant, Upper GI and Bariatric Surgical Section, Department of Surgery, Tan Tock Seng Hospital, Singapore. He is going to talk about laparoscopic bariatric surgery in COVID era. Dr. Aw Mien Ooh, please.
Thank you, Siai, for the kind introduction. It is my great honor and pleasure to be invited for 67 Myanmar Medical Association Conference. So today I was tasked to give a talk on the laparoscopic bariatric surgery in the COVID-19 era. So I've no financial disclosure. So the hospital I work in is the Tan Tock Seng Hospital. It's the second largest hospital in Singapore. It's located in the health city Novena, which is centrally located under the National Healthcare Group cluster. So we all know that COVID-19 has effectively affected all our life, with the global cases of 98 million cases as being patients have been infected with the COVID-19, together with the 2.1 million deaths as of yesterday. I got from the Johns Hopkins University website. So COVID-19, due to the COVID-19 pandemic, a lot of things has been need to be wisely managed in terms of the resources. This is the Lancet journal saying about the effective and equitable decision making is important during the pandemic. So we need to, due to the shortage of the emergency and critical care clinicians for the bedside care, rapid changes in the number of patients, and then other specialist care resources. So we need to make sure that the resources are appropriately managed during the COVID-19. So then how about the obesity? So obesity is, we know that it's an epidemic. The obesity has been, the WHO identified as a chronic medical conditions to the disease state, as well as is a overwhelmingly epidemic. So that's why we use the word globally. It's globally, obesity patients has been affected during the COVID-19 as well. So as of the WHO, worldwide obesity has nearly tripled since 1975. We have a 1.9 billion adults in 2016 were overweight, and then 650 million were obese worldwide. And then 39% of the adult age 18 years were overweight in 2016, and 13% were obese in terms of the percentage. So we are dealing with the obesity and overweight issues worldwide as well. So we all know that obesity can give rise to a lot of medical problems, including the depression, hypertension, cardiovascular disease, to all the metabolic related syndromes, type 2 diabetes, etc. So the study has been proven that obesity and bariatric surgery the bariatric surgery can help reduce the comorbidity in the obese patients. You can see the quality of life can improve in the 95% of the patient, together with the 89% reduction in the 5-year mortality by going through the bariatric surgery for obese patients. So what are the benefits of the bariatric and metabolic surgery? This is the ASMBS, American Society statements, guidelines published in 2016. We all know that bariatric and metabolic surgery is associated with the reduction in the all-cause mortality and increased long-term survival. And then metabolics and bariatric surgery is significantly superior to the current best medical management of the treatment and remission of type 2 diabetes, and also reduces the death rate associated with type 2 diabetes. Since 2016, the evidence are still stronger and stronger. And then metabolic and bariatric surgery is associated with the reduction of the cardiovascular disease risk factors and future CVD events and deaths. And also the reduction in the risk of certain cancers related to the obesity, and improve cancer outcomes and mortality for women as well. So we know that obesity together with the breast cancer, and then doing the bariatric surgery, but also surgery for the obese ladies can help with the reduction in the breast cancer as well. How about COVID-19 and obesity? We all know that COVID-19 affected for those patients with the non-communicable disease, especially cardiovascular disease and type 2 diabetes, which are the main risk factors and main medical conditions in the obese patients. So the WHO has highlighted that NCD is as a risk factor for becoming seriously ill with the COVID-19, and that emerging data has been suggested that obesity is a key risk factor for the COVID-19 complications. And having the higher BMI can increase the risk of the severe illness from the COVID-19, as of the CDC statements published. So why COVID-19, obesity wasn't the COVID-19? You can see that many obese patients on the ventilator in this article published in the Science, published in 2020, September. So extra kilos, you can see that the higher the BMI, the higher risk of the COVID-19 hospital admissions. So this is the paper published in the Obesity Reviews journal about the individual with obesity and COVID-19 causing the biological and epidemiological relationships. So in this systematic review, we know that individuals with the obesity were more at risk for COVID-19 positive. This is 46% higher for hospitalization, and then 113% higher for ICU admission, 74% higher for mortality, and then a 40% increase in the deaths. So why is it so? You can see that obesity together with COVID-19 add together have a lot of mechanistic change, including the metabolic dysfunction, immune impairment, adipose inflammations, and then adding on to a lot of the pre-existing comorbidity in the obese patients, such as metabolic syndrome of the hypertension, cardiovascular disease, type 2 diabetes, and then also the physically, because of being obese, have a pulmonary dysfunction, including the obstructive sleep apnea due to the visceral adiposity and the physical activity, all added together lead to the clinical manifestation of the increase in the hospitalization, ICU admission, and mortality, as well as the ARDS and then the acute lung injury, etc. And then they have been advocating that there is the risk that vaccine may not help efficiently in the obese patient due to the decrease in the T-cell memory, as well as the long life B-cell antibody protections in the obese patients. So this is quite alarming, and then we need to deal with the obese patient and how to help them to overcome this, the COVID-19. We all know that bariatric surgery is very established for obesity treatment, as I mentioned earlier. So bariatric surgeries, these are the most common type of bariatric surgery performed worldwide since the bariatric surgery was started. So the gastric banding is less and less popular due to its side effects. And then we are doing more and more sleeve gastrectomy and Roux-en-Y gastric bypass so far, and as well as the other coming up with the new procedures. But so far, the standard approach has been these four, and then more commonly done worldwide sleeve gastrectomy and Roux-en-Y gastric bypass for the time being. We all know that bariatric surgery in obese patients, open surgery is very difficult with a lot of the complications from the open surgery, including the wound infection, a lot of pain-related issues, and thus we move to the laparoscopic approach for the bariatric surgery, and then almost 100% of the patients, if can do the laparoscopically, we do laparoscopy for bariatric surgery, and then more than 95%, 99% of the patients are done laparoscopically successfully. A very few patients need to be converted to open, and then almost certain in nowadays era of the advancement in the laparoscopic surgery. So we know that MRS during the era of COVID-19, the SAGES, the EAES recommendation for surgical response, laparoscopy is actually, we don't have much evidence of the MRS risk specific to the COVID-19, and then the proven benefits of the reduced length of stay and fewer complications in the laparoscopic surgery has been well known. And then some of the things I think Dr. Professor Allen has mentioned about the device to filter the release of CO2, minimize use of energy devices has been recommended according to SAGES and the EAES. And so mainly is the personal protection is the mainstay to help to reduce the risk of the infection to the surgeons. So you can look at that. There's ELSA. I think Prof. David Lomanto is the main author for this ELSA recommendation, and then I think he has shared just now. So we have a strategies to patient selection to surgery during the COVID-19 for outbreak, and then we can see that we have a very established kind of guidelines and then the strategies to deal with the surgery during the COVID-19 era. So this is a very, very interesting paper on the medically necessary and time-sensitive procedures during the COVID-19 pandemic published. You can see that we have the authors came up with the procedure factors on the scaling of the 1, 2, 3, 4, 5 for the scoring, and the disease factor of the scoring of 1, 2, 3, 4, 5 again, and the patient factors on the age, including the lung disease, OSA, CV disease as the patient factors for the proper scoring, and then to see this MENDS score and then decide whether it's okay to proceed or reserve OR capacity for emergent, urgent cases or procedure not justified in terms of the triaging for the justification to proceed with the surgery during the pandemic to prevent from the unnecessary excessive risk to the personnel to excessive resource utilization due to the unnecessary surgery. And then this is the proof of concept, and they did some testing, and then it is well justified for the procedure. So American College of Surgeons also provided with some elective case triage for multiple surgical care, but this for the metabolic and bariatric the surgery specific. So they categorize into the emergency needs, which is a life-threatening, we should proceed, especially for the bariatric. There's a perforated vaginal ulcer from the post-gastric Roux-en-Y gastric bypass, bleeding, anastomosis or stable line lead. In that case, no choice, we have to go in and deal with the patients to save the patient life. And the urgent needs, which can be delayed by a few days or weeks, like a pediatric revision for dysphagia, severe GERD, it can be considered as urgent needs, and then we can probably delay, depends on the resources constraints in the local hospitals. So for electives, maybe delay for months without treatment or like for organ damage, then probably we can delay to the slightly elective approach and a slightly later take when the results are more possible. So these are ASMBS statements of the published for the COVID-19 last year. Is the metabolic and bariatric surgery is not considered elective because they are medically necessary, and then the best treatment for those with life-threatening and life-limiting disease or the severe obesity. So it should be restarted when it is safe to do so. And then he did disagree with the concept that bariatric should be postponed until the pandemic is declared over. So we should thinking of the reopening the bariatric surgery whenever its resources are allowed in the local institutions. So factors to consider in the making the decision will be the local prevalence of COVID-19, availability of the testing, available resources, including the hospital beds, ventilators, and personal protection equipment in the local settings, and then also strategy to protect the healthcare workers and patients. This is important. If as far as we can deliver all these important considerations, that probably we can restart back the medically necessary pediatric surgeries during the pandemic, before the pandemic is completely over. So this is the GENEVA Study. It is called the Global 30-Day Outcomes of the Pediatric Surgery during the COVID-19 pandemic. It's an international cohort study by Professor Mahar from the UK has done this review. And we know that there is no difference between the pre-COVID-19 and the COVID-19 eras for the pediatric surgery. So there's nothing much the evidence to say that we should postpone the pediatric surgeries during the COVID-19. As far as the resources are available, and then we can have a very safe surgery during the COVID-19 period, we can consider restarting the laparoscopic pediatric surgery for these patients to help those patients. So how about the Singapore response? We noted that it's 23rd Jan to 2020, we have the first COVID-19 case in Singapore. And then we, as Prof. David Lomato mentioned about the DORSCON alert levels, we moved to the DORSCON orange immediately after the 7th February 2020. And then we have a circuit breaker for the 7th April 2020 to 1st June 2020 for 7th February, where it's like a partial lockdown. And then we have phase opening, phase 1, phase 2, phase 3. Phase 1 started back in 2nd June 2020, and phase 2 back in 18th June 2020. And then we just started phase 3 last month on 28th December 2020. And then we have a first COVID-19 vaccines given on 30th of December 2020. 30th of December 2020. So this is a current summary of the COVID-19 cases. So we don't have much of the community cases. Go to the good measures implemented in Singapore. So we have also restarted back the bariatric surgery, slowly opening up with the elective setting since October 2020. So this is my take-home message. COVID-19 is pandemic and require a lot of healthcare resources and also cause a constraint to the healthcare systems. Obesity is a rising global health problem as well, and it is an epidemic. Bariatric and metabolic surgery is beneficial to over all the patient's outcomes, including the reduction of the morbidities and all-cause mortality for those obese patients with the metabolic disease. Most of the bariatric surgeries performed worldwide are minimally invasive, and minimally invasive are found to be safe during the pandemic. So bariatric and metabolic surgeries for obese patients, especially those with a metabolic syndrome, may be considered as a medically necessary in the time-sensitive procedures measures during and post-pandemic era for triaging. Welcome to Singapore. Thank you very much.
Thank you, Komiu, for your very informative lecture. Since the time is very limited, so I would like to conclude the section and skip the Q&A sections. So I would like to thank MMA 67 conference organizers for arranging this very informative symposium, and I would like to thank all the three distinguished speakers, David, Alan, and Komiu, for giving us highlight our knowledge and giving us a very informative lectures. And I would also like to thank Sea Lion for sponsoring this section. So thank you very much to all the participants as well. There I've seen more than 100 114 participants, attendees. So this is a very successful symposium. Thank you, David. Thank you, Ellen. Thank you, Guamiu. Thank you very much to you all. So
thank you all. Thank you.
Thank you.
Please take care. Stay safe, everyone. Bye-bye.
Bye-bye.
Thank you.
Bye-bye.
Thank
Hey,
you.
bye-bye.
Bye-bye. Bye-bye.
Jesu Dumare.
Jesu Te Pare.